Hello, I'm Kathleen. I'll be performing an SFMA Talk to Your test on you. This is just testing your muscle functionality and joint play. I'm going to have you do a cervical spine flexion to start out, and I'll walk you through all the steps for the rest of them as well. The cervical flexion just tests your ability to flex your cervical spine. So all you have to do is touch your chin to your sternum. Go ahead and do that and hold it there, keep your mouth closed. Alright, you don't have any space between there, so you're touching your sternum pretty good. Go ahead and do it one more time. Alright, doesn't look like he has a uniform spinal curve. It is kind of flat right here. And then, was there any pain with that when you did that? Any excessive effort? Shaky? Cool. So no excessive effort or lack of motor control in the cervical spine. Alright, so we're going to do cervical extension next. Okay, this is just gonna, same thing but the other direction. What I want you to do is look up to the ceiling as far as you can. Alright, any pain with that? Okay, so do it one more time. Alright, he's within 10 degrees of parallel. He only bends at one segment of the spine. So I would say that would be dysfunctional. And then any excessive effort? No? Good? Okay. So flexion would be dysfunctional, non-painful, and cervical extension would also be dysfunctional, non-painful. Okay, so next we're going to do cervical rotation. So what I'm going to have you do is, this just tests the bilateral cervical rotation, free movement. You're going to basically just turn to the left and turn to the right when I tell you to. Alright, so go ahead and turn to the left. Okay, and now turn to the right. Any pain with that? No? Okay. And one more time, and I'm going to come from the side here. Okay, and then look at me. Alright. Chin is in line with the mid-clavicle. Was there any excessive effort? Was it hard to do? Okay, cool. So, do it one more time for me. Okay, and then the other side. I would call that functional. Yeah, there's no tilting of the head or compensation with the movement. Next, we're going to have you do a shoulder pattern. So I'm going to step behind you. You stay facing that way. This just tests your shoulder internal rotation, shoulder extension, elbow flexion, and thoracic extension and rotation. So what I'm going to have you do is, basically you're going to bend your Elvis and reach over your head like you're pushing your hair out of the way and touch the opposite shoulder. Alright, and then do it the other side. Okay, and then one more time. And the other side. Alrighty. So he was able to reach the angle of the scapula on both sides. He did compensate a little bit by moving his head forward. I would say dysfunctional, non-painful for the right, but not the left. So the left would be functional, non-painful. You're going to reach behind you and touch the bottom of your scapula on both sides. Okay. Okay, other side one more time. And the left side. Any pain with that? No. Okay. He was able to reach the inferior scapula, didn't have to compensate using the wrist at all. I would call that functional, non-painful. Alright. And stand back up. Okay. And then Do it one more time for me. So the lumbar spine is kind of flat there. Go ahead. Alright, so you can touch your toes. Your sacral angle is less than or greater than 70 degrees. You don't have a uniform spinal curve. It looks like most of your curve is up in your thoracic because your lumbars are kind of flat. And was there any excessive effort with that? No pain?
No.
Okay, so that would be dysfunctional, not painful. Okay, and then the next test, what I'm gonna have you do is I'm gonna have you put your hands above your head,
Okay.
and then lean back as far as you can.
Yep.
Okay, any pain with that? No? Can you do it one more time?
Sure.
All right. So the upper extremities, when you do that, maintain 170 degrees. The ASIS has cleared the toes, and the spine of the scapula is able to clear the heel. Can you do it one more time for me?
Sure.
Okay. It doesn't look like he has a uniform spinal curve. He's mostly hinging in the lumbar region. You said there was no effort or locomotor control with that, no pain? Okay, so again, dysfunctional, non-painful for that one. All right. So the next test I want you to do is you're just gonna rotate as best you can, as far as you can, on both sides.
Okay.
Put your feet together, please.
Okay. Good me.
Yes. Okay, and the other side. Alright, so pelvis rotates greater than 50 degrees, greater than 50 degrees on both sides. Torso rotation was greater than 50 degrees on both sides, so that's good. And then, was there any pain with that? Any effort? Excessive? Alright, so that was functional, non-painful. And then next I'm going to have you do a single leg stance. So this tests your balance. So this evaluates the ability to stabilize and independently on one leg in a static posture. What you're going to do is you're going to stand on one leg with your eyes open for 10 seconds. Same leg, I'm going to have you close your eyes for 10 seconds. And then we're going to flip to the other leg, okay? Alright, go ahead. Alright, close your eyes. Same leg, same leg. Now close your eyes. Okay. And then keep your eyes open stand on the next leg. Alright, now close your eyes. Okay, you're good. Any pain with that? No? Okay. So you were able to do both for 10 seconds pretty well. You didn't stumble too badly. Any excessive effort with that or pain?
No pain.
No? Okay. So I would say that's functional, non-painful on both right and left legs. This is the fun one. So this is called an arms down deep squat. This tests for bilateral symmetry and mobility of the hips, knees, and ankles. So I'm going to show you real quick how to do it. So what you're going to do is I want you to squat as far as you can and then put your hands down.
Do I need to, I guess, do I need to keep my feet
Yeah,
flat?
keep your feet together.
Together?
Yep.
Not flat.
Yeah, that's
Okay, alright.
yeah, okay, and then do it one more time. and put your hands down, arms down.
That's what you asked. What do you?
And then
Okay.
do it. Yeah. Okay. So hips were able to break parallel. Can you do it one more time?
Sure. That's the way my knees work.
Okay, good. Yeah, your hips were able to break parallel. You cannot reach your fists to the ground though. You didn't lose any of sagittal plane, like you didn't fall over or anything like that. So I would say it's dysfunctional, non-painful. I'm assuming you didn't have any pain with that. Okay. And that's the fun. Alright, I'm going to be performing a straight leg raise test on you. This is a high sensitivity and low specificity for lumbar nerve root and impingement. A negative test is a good result. It's ruling out any problems. Positive test is provocation or reproduction of symptoms. So that would be pain in the L4-S2 region, which is your lower back and your hips. And then it's going to be most sensitive where your hips start. And then a positive test also indicates either L4 or S2 nerve root impingement or your sciatic nerve tension, sciatic neuropathy. So we're going to be looking for that today. Alright, so I'm going to start with this leg by grabbing under your Achilles tendon and holding on to your knee. I'm going to take you up all the way. Tension here.
Keep going.
Here.
Keep going.
Okay, and then I'm going to bring you back down. Dorsiflex the foot, and then I'm going to do it one more time. Tell me when you start to feel tension. Right here. Okay. That is, I would say, about 80 degrees still. Right, and then I'm going to do it on the other leg. Right under the Achilles tendon, holding on to the knee. Tell me when you start to feel tension. Okay, and then I'm going to bring you back down. Dorsiflex the foot.
Okay.
And then bring you back. Okay.
So today I'm going to have you go through a slumps test, which is testing the lumbar spinal roots as well as the sciatic nerve, which is testing for L4 through S3. And so I'm going to have the patient put his arms behind his back for me. And then whenever there is any tension or pain, just let me know. So in a second, I'm just gonna have you tuck your chin out and then extend this left knee for me. Good, and I'm gonna bring chest to here, and right there. All right, and then we're gonna do that one more time. And now I'm gonna have you look up, and I'm having the patient look up to relieve that tension.
Okay.
All right, and then relax. And then was there any change when I had you look up? Was there any extra or less tension compared to the other one?
Maybe a little less.
Okay, sounds good. All right, and then I'm gonna have the same thing on the other side. So I'm gonna have the patient extend that right knee, good, and then tell me when.
Okay.
Good, and then relax, and then same thing, and then look up to the sky, and then the patient can go a little bit farther. For a positive test, we'd be looking for any shooting, radiating pain. Patient did not have any overwhelming symptoms of that, which would conclude that it is a negative test. We're also looking for numbness and tingling in that sensation, which is negative. So this is a negative test on this patient.
So we're going to be doing the femoral nerve stretch test, which is a test for the mid lumbar. So we're going to be testing levels 2, 3, and 4 for nerve root impingement. And then we're also going to be testing our femoral nerve for tension, nerve tension, or neuropathy, so tingling, paresthesia, stuff like that. Positive tests would be pain in the groin or the anterior thigh, and or calf, ankle, and foot. Have our patient laying prone on the table. His trunk and pelvis are in a neutral position. We're gonna grasp his lower leg, bring it up, ask our patient if to tell us when he feels any tension or pain with it. We're gonna want him to go past 90 degrees. So he's past 90 degrees. Feeling any tension with that?
No.
I feel a little tension. Put overpressure on the pelvis. Any pain with that?
No.
Right. And then I'm gonna come back up off the 90 degrees back to neutral. So we're gonna go over and do it again on the other side. So bring up to 90 degrees. Go until we feel some tension, which be right there. Put overpressure on the pelvis. Any pain with that?
No.
Okay. And then relax back down, continuing to maintain pressure on the pelvis until the limb is in a neutral position.
All right, so now we're gonna be doing some objective assessment as far as breathing and looking at the core stability and just breathing overall in general. So first I'm gonna have the patient with any clothes of the shirt off so I can assess the different rib exposure as well as the traps and the side of the abdomen and the back. So first I'm gonna have the patient, I'm just gonna have you breathe normally in and out and sitting up nice and tall already, perfect. So I'm looking for any normal breathing or dysfunctional breathing, which would be any applicable or paradoxical breathing. So first I'm gonna palpate and bring into the side of the patient and feel, again, just breathe normal for me, feeling the expansion of the rib cage and the lumbar area into my hands. And then next we're going to be visualizing kind of the respiration of the posterior thoracics, if there's any full breaths, and then also just lightly palpating the upper traps, seeing the tonicity of them, the levator scapulae, T11 and 12 interthoracic intercostal spaces, and then lastly finishing with the anterior, the lateral, and the posterior abdomen, with the thumb again coming in and just feeling the expansion. On this patient had minimal expansion into my hands closer towards the hip, which would be consistent with abnormal breathing. Okay, so next I'm gonna have the patient go back on their back here all the way, perfect. And so now I'm just gonna have you put one hand on your chest and then one on your tummy for me, perfect. And I'm just gonna have you breathe normal. So this, I'm having the patient assess themselves to begin with, feeling the normal pattern of their breath, if there is more in the chest area or if there's more in the lower abdomen area. Okay, so after I have them do that for a little bit, I'm gonna have, next, I'm just gonna have you touch the side of each of your hips, perfect for me. And then I'm gonna have you notice kind of if there is expansion into like the web of your thumb and your first finger and where that placement is, if it's more anterior in the front or if it's more on the side, if it's more in the back of your hands, just overall. Okay, and then after I have the patient do that, next I'm gonna have one hand on the stomach and then one behind, perfect. And then again, feeling that assessment, seeing where the breath is coming from, if it's more anterior or if it's more posterior. And then after a bit, I'm gonna have the patient put their hands towards the inward of the pelvis. Perfect. And then I'm just gonna have you use like your index and your middle finger and kind of push it down onto that. And then again, feeling where the breath is coming from. And then after a little bit, I'm just gonna have you put your hands to your side for me, and then I'm gonna be palpating the patient. So is it okay if I come in? Perfect. So I'm just feeling, just breathe normal for me, just in and out. Patient is breathing more on the abdominal area compared to the upper chest, and that would be indicative of more of diaphragmatic breath and breathing, which is good. And then now I'm just gonna have one hand on here and then bring it onto the bottom, and then assessing. There's minimal posterior breath and compared to the anterior. And then now I'm just going to have come into your hips, and then I'm just feeling on an anterior version of before, feeling how the and I consistently still feeling more anterior breath. And then now I'm going to come into your hips. So just let you know, coming in and feeling and assessing the breath and minimal breathing or palpation of the inguinal section. Okay, and now I'm gonna have the patient go into what I call a dead bug position. So I'm gonna have the patient bend their knees for me and then lift those feet into the air, and then both hands go up. Yeah, perfect, just like that. So I'm gonna have the patient supine in this dead bug position, and I'm gonna bring their legs up to help, and then I'm gonna slowly release that my support, and I'm gonna have the patient keep those legs up for me. Perfect. And then for this one, we are looking to have this be held for about 30 seconds to a minute. I'm just gonna be looking at the breaths of the patient while they hold this position. I'm looking for if the spine maintains on the table or if it lifts up. For this case, I'm seeing slight anterior position of the breaths, as well as I'm looking for different loss of activations in certain areas, specifically in the abdominal wall, and any change of the anterior head carriage, or looking at the position of the head on there. And if I find any of these, this would indicate spine, trunk instability, or core weakness within the abdominal muscle. All right, relax. Perfect.
So I'm going to be doing the deep neck flexor endurance test today. So I'm going to have my patient retract or tuck his chin in, and then flex your neck and look at your toes, and I'm gonna have you come back down a little bit so your head is barely an inch off the table, and you're just gonna hold that position for me. So I want him to hold this position for about 40 seconds. This is testing his deep neck flexor muscles, and so I'm watching to make sure that he's not excessively shaking, or he's still breathing well, and that his head is still slightly off of the table. He's not going to touch my hand with his occiput. His chin is still retracted. I'm watching to make sure that his neck folds don't change at all, and he's good. So you can relax now. He made it to 40 seconds. And so if he hadn't made it to 40 seconds, that would indicate that he was holding his head up with more of his SCM instead of his deep neck muscles, and that would make him have more of like an anterior neck carriage and also potentially have neck pain. So next we're going to have him scooch a little farther down towards me a little bit. So now we're going to do the OA cervical flexion test. So this is testing our occipital atlantal joint, and the patient's going to be supine, so on his back, and we're going to passively rotate his head as far to the side as it'll go. So this is a pretty good, like pretty normal place to be. And then I'm going to ask my patient to tuck his chin and try to touch his shoulder, which he gets to, so that is good for him. And then I'm going to do it as the clinician, and I don't feel any real joint restrictions. So then we're going to move back to neutral and do the same thing on the other side. So rotate, ask him to tuck his chin in. That side's a little better than the other side, and then I'm going to do it. And back to neutral. So normal movement is about 20 degrees of flexion bilaterally, and he definitely gets that. If it was dysfunctional or he couldn't get to 20 degrees, it would be indicating a occipital atlantal joint mobility dysfunction. We ready?
Mm-hmm.
All right, so next we're gonna do our C1, C2 cervical rotation test. So I'm gonna take my patient and fully flex his spine to lock out the lower cervicals. And then I'm going to passively rotate his head. And we want him to get past 44 degrees. So he definitely makes it past that 44 degrees mark on the left, and then on the right, he also makes it way past 44 degrees. And then I'm gonna ask my patient to do it actively. So can you turn your head to the left?
Mm-hmm.
And he can get there. And can you turn your head to the right? And it's a little harder on that side, so that might be a little bit of a motor control issue. Then we're gonna relax. Bring your head down. So if he couldn't get to 44 degrees, over 44 degrees on either side, passively or actively, it might indicate a C1, C2 joint fixation or restriction, and he would be at an increased likelihood for cervicogenic headaches.